Good afternoon, everyone. My name is Pedro Gonzalez. I choose the topic of incidental pulmonary nodules since my grandmother had an incidental pulmonary nodule this year, and it turns out it was an adenocarcinoma. So I thought it was a good opportunity to review that. Okay, so the resources I used were the Fleshner Society guidelines for management of incidental pulmonary nodules, information from UpToDate and Radiology Assistant. So first, it's important to differentiate between a pulmonary nodule and a pulmonary mass. A mass is typically a round lesion that is more than 3 centimeters. A mass of this size is treated as malignant unless proven otherwise. A nodule is typically 3 centimeters or less, is well marginated, discrete, and is surrounded by lung parenchyma. It's important to note that a solitary pulmonary nodule does not touch the ileum or the mediastinum and is not associated with atelectasis, pleural effusion, or enopathy. Solitary pulmonary nodules are further classified as solid and subsolid, and the subsolid nodules are subdivided into pure ground glass and partial solid. So in this image, in the first image is depicted dense nodule with irregular margins. This is consistent with a solid nodule. And in the middle, there is a nodule with a solid component, a solid core, and underlying or surrounding increased density. That is a ground glass density. Ground glass density is, the density is higher than the pulmonary parenchyma, but it's not enough to obscure the bronchovascular markings. And the third image is a pure ground glass nodule. So these 3 nodules are different ways lung adenocarcinoma can present. And lung adenocarcinoma is the most common lung malignancy that presents as a solitary pulmonary nodule. So anytime a pulmonary nodule is detected, it's important to know in which image modality it was detected. If it is detected in a plain chest X-ray or a chest CT with thick sections, it's important to check prior images and evaluate the nodule properly with a chest CT with thin sections, that is 1 millimeter or less. This is the optimal imaging modality, since small solid nodules in thick sections, in chest CT with thick sections, can be ground glass in appearance if they are very small. It's important to know also that the word incidental is important for the definition of incidental pulmonary nodule. This is because the Fleshner guidelines applies not to all nodules. It applies to people or patients that are more than 35 years old, since the ones that are younger than 35 years old usually is a benign etiology. It also applies to people that are not symptomatic, that don't have like symptoms of pneumonia, that are not immunocompromised, and don't have history of malignancy. This is also important since immunocompromised patients, the etiology is usually infectious, and patients with an already known history of malignancy have 25% of metastasis if a lung nodule is detected. Also, the nodules that are detected during lung cancer screening, that this screening is indicated in patients with more than 20 year smoking history, active smoking, or having quit within the past 15 years, or patients between 50 to 80 years old. These patients are evaluated with a different criteria. That is the lung RATs. That is not covered in this presentation. So it's important to know this before applying the Fleshner guidelines. So most of the time, a nodule will be detected in a plain chest X-ray. And most of these nodules will require a chest CT without contrast and thin sections. In the literature, it's described that sometimes in some scenarios, some of these apparent nodules won't require a chest CT with thin sections. Those cases are when the nodule is likely a nipple shadow. The nipple shadow can be evident if it's bilateral, but sometimes just one nipple can present as a pulmonary, like an apparent pulmonary nodule. So in this case, we can apply a chest X-ray with nipple markers. And another scenario is if the patient has symptoms of infection. In these cases, pneumonia is suspected, and chest X-ray in 6 to 8 weeks is recommended to obtain to ensure resolution after treatment of pneumonia. So in this case, in this chest X-ray, we can see that in the left lung, like in the left lower lobe, over the 8 posterior rib, there is an apparent nodular opacity. And in the second image, we can see that the opacity fits within the circle that is a radio-opaque body, that is the nipple marker. If the radio opacity stays within the nipple marker, is a nipple, and if it is not inside the nipple marker, then probably is a solid pulmonary nodule, and a chest CT with thin section is recommended. So the differential diagnosis include malignant etiologies and benign etiologies. Primary lung cancer, I already said that adenocarcinoma is the most common cancer that presents as a solitary pulmonary nodule, followed by squamous cell carcinoma and large cell carcinoma. Metastatic cancer include colon, breast, kidney, testicular cancer, melanoma, and sarcomas like osteosarcoma and chondrosarcoma. And carcinoid tumors in 20% of cases can present as peripheral, well-circumscribed pulmonary nodules. Infectious includes granuloma. In 80% of the benign etiologies are granulomas. This can be due to Mycobacterium tuberculosis, but also by endemic fungi like histoplasmosis and coccidioidomycosis. In the 10% of benign etiologies, there are the hamartomas. There is also the pulmonary AB malformation, like hereditary hemorrhagic telangiectasia. Other etiologies include Wegener, granulomatosis, rheumatoid arthritis, sarcoidosis, or peripheral lymph nodes. So in this image, we can see in the chest X-ray that in the right lower lobe, there is like a circular, well-circumscribed opacity. This was further evaluated with chest CT, and in this case, this chest CT was evaluated with contrast. So we can see that the nodule have like two lines, one thick line and one thinner line. The thick line is a large draining vein, and the thinner line is a feeding artery. So this is the typical presentation of AB malformation. And just like in this case, is indicated the use of chest CT with contrast. Typically, in the evaluation of pulmonary nodules, contrast is not necessary. But if we have this suspicion of AV malformation, then contrast can be used, such as this case. Peripheral nodes are also another differential. They are benign, and if they are present, no further follow-up CT is indicated. They represent intrapulmonary lymph nodes, and they have a specific shape and location. So the shape is usually in the axial images, they are triangular or oval. Their location is juxtapleural or is close to the lung fissures. They are homogeneous and with smooth margins. In this case, we are seeing that a triangular configuration close to the pleura, and also they can have a fine linear extension to the pleura. This is another example. We can see the lung fissure, and there is a homogeneous density with a triangular shape that is located close to the fissure, so it's most likely a peripheral node. In this case, we are seeing also a peripheral node, but this one doesn't have a triangular configuration. It's more like an oval configuration. It's also another type of shape of the peripheral nodes, and is benign. This is the classic finding in axial images. The shape is triangular, and when we evaluate the opacity in coronal view, if it is flat or lentiform, then it's most likely a peripheral node. More examples of peripheral nodes located within the fissures. One triangular in the first image, the second oval. And not every apparent nodule close to the fissure is a peripheral node. It's important to identify all the characteristics I already told, because in this case, the shape is not typical. It's not triangular, it's not oval, flat, or lentiform. The margins are not well circumscribed or smooth. The nodule have increased, is heterogeneous, has some increased densities inside. So this is not a peripheral node. This is most likely a pulmonary nodule, a solid nodule. And in this case, it should be evaluated with further chest CT with 10 sessions. So the likelihood of malignancy is determined by clinical features and radiographic features. And there are some quantitative predictive models, some calculators that can be used to put the patient in low, intermediate, or high risk for malignancy. And with all that information, further decisions can be made between CT surveillance, PET-CT, lung biopsy, or resection. So I'm going to start with clinical features. Age is a major clinical feature. More age represents more risk for lung cancer. And this risk starts at 35 years old. Before 35 years old, the risk is less than 1%, and typically CT surveillance are not indicated. But after 35, the risk starts to increase more than 1%. And we can see that after 60 years, the risk is more than 50% that a nodule could be a malignant nodule. Female gender is also a risk factor. This is because adenocarcinoma is the most common etiology that presents as a solitary pulmonary nodule. And also adenocarcinoma, sorry, adenocarcinoma doesn't have a strong relationship with the smoking. And it's most common in females. Family history of lung cancer is also a clinical feature, important. Race, Black men and Native Hawaiian have increased risk compared to white men. Some comorbidities like emphysema predominant, COPD, and idiopathic pulmonary fibrosis are also risk factors. Smoking history. This is particularly important for squamous cell lung cancer, large cell carcinoma, and small cell cancer. Not so much for adenocarcinoma, but it's an important risk. And inhaled carcinogens like asbestos, radon, and uranium. So now the radiography features. So the nodule size is very important. If the size is bigger, then the risk of malignancy is higher. So we can see in the three images that are in my slide, the actual coronal and sagittal views. When evaluating nodule size, it's important to review these three views and to use the view that has a higher lung axis as reference. It's important to evaluate the nodule on long windows. And in the table that is green below the image, we can see that the risk of malignancy is higher as the nodule gets bigger. And a nodule that is more than 3 centimeters, that is not a nodule, it's actually a mass, is resected because it's considered malignant unless proven otherwise. How do we measure the nodule? For solid nodule and pure ground glass nodules, we typically measure first the long axis, that is this one, and then the short axis. We sum both values and then divide it by 2. So it's an average of both dimensions. And in the case of subsolid, partial solid nodules, we perform the same with the entire nodule and then with the solid component. In this image, there is a solid pulmonary nodule. The long axis is 16 and the short axis is 14. The sum of both is 30, and if we divide it by 2, is 15 millimeters. So the average size is 15 millimeters for this lung nodule. This is how we measure the partial solid nodules. So the first, to measure the entire nodule, the long axis in this case is 25 millimeters and the short axis is 23 millimeters. And then we measure the solid component. The guidelines recommend that if the nodule is bigger than 10 millimeters, just report the long and the short axis, and that's it. And if the nodule is less than 10 millimeters, report the nodule as the average of the long and short axis. And for partial solid nodules, if the solid component is more than 3 millimeters, then just report the long axis of the solid nodule. Okay, nodule density is very important. Solid nodules are dense and homogeneous, whereas subsolid nodules have less than soft tissue density, and bronchovascular structure can be visualized. In between all the type of lung nodules, the partial solid nodules are the ones that have a higher malignancy rate. So if you can see here, the partial solid have a malignancy rate of 63%, followed by pure ground glass that have a malignancy rate of 18%, and solid nodules that have a malignancy rate of 7%. Also, the density of the nodules can affect the way the nodule is diagnosed by biopsy or characterized by functional imaging or PET-CT scan. So in the case of solid nodules, when they are sub-centimeter, less than 1 centimeter, but specifically 8 millimeters or less, they are difficult to biopsy and can be really be well visualized or characterized by functional imaging. If the solid nodule is more than 8 millimeters, then it's most likely to be successfully diagnosed by biopsy and characterized by functional imaging or PET. And for subsolid nodules, also they are less amenable to PET and biopsy compared to solid nodules. Growth or a stable size is also a radiographic feature. So there are some definitions for nodule growth and nodule stability. Growth is determined in solid nodules by an increase in average diameter by at least 2 millimeters. And in subsolid nodules, it's also an increase by at least 2 millimeters, but there are also additional findings that are increased density or increased attenuation over time, the development of a solid component, or an enlargement of the solid component. If a nodule meets criteria for nodule growth, then it's considered malignant and biopsy resection is indicated. Nodule stability is also important to know the definition. For a solid nodule is if the nodule is unchanged by CT for at least 2 years, and for subsolid nodule, if the nodule is stable by CT for at least 5 years. If a nodule meets criteria for stability, then it is benign and further workup should be avoided. So in this image, we are seeing an actual view of a chest CT. We can see a solid nodule that is increasing in size from March 2010 to April 2011. And we can see that the initial average diameter was 8 and the final average diameter was 13. So this nodule meets criteria for growth and it should be biopsied or resected. This is an example of increased density. This is a characteristic of growth in subsolid nodules. In the first image in May 2013, we are seeing a ground glass pulmonary nodule. And in May 2016, we are seeing a nodule that has increased density compared to prior images. So this finding is consistent with growth and it should be biopsied or resected too. And this is an example of development of solid components. So in the first image in June 2013, we are seeing a ground glass nodule. And then in June 2016, 2 solid components are now present. So this is also consistent with growth and it should be biopsied or resected. Another radiography feature is calcification and fat. There are some benign patterns and some malignant patterns. The benign patterns are the ones that are depicted in the image. Diffuse is that the entire nodule is calcified. It has the same density as bone. Central is just the center of the nodule is calcified. Popcorn is that the calcification have like this specific pattern that looks like a popcorn. Concentric is that there is calcification, but like in a laminated forms and a concentric way. And malignant includes eccentric calcification or ground glass calcification. So in the case of a diffuse calcification, it is most commonly granuloma. Granuloma are also have a diffuse, central, and laminated or concentric calcification. So these 3 patterns can represent granuloma. Unfortunately, some types of metastases can present as a diffuse calcification, specifically osteosarcoma or chondrosarcomas. Popcorn calcification is the feature of amartomas. It's the classical feature, but is present just in 10% of cases. Typically, amartomas have can have a popcorn calcification, can have fat within the nodule, like this one, or can have a mix of both. So in this case, this is an amartoma with calcification, and there are some fat densities located. This is also an amartoma, is a bigger one, but also the calcification pattern is characteristic, so it's a benign. It's benign. In this case, this is another way a amartoma can present. In this case, this amartoma doesn't have calcification, but it has fat. And this one is also a nodule that on fluorescent CT, when the mass was measured with the Hounsfield units, it was -30 Hounsfield units, consistent with fat density. So this was an amartoma too. Another radiographic feature is the margins and the location. So if the margins are well defined and the border is smooth, then it's most likely benign. If the margins are spiculated, this is a high risk feature, and it represents the growth of malignant cells along the lung interstitium. If the margins are lobulated, it's an intermediate risk, but it's also suspicious, and it represents different growth rate within the lung. And also, if the nodule is present in the upper lobe, then the risk of malignancy is higher than the location in another lobe. So in this image, we are seeing a nodule that is well circumscribed, is smooth and dense. It's a solid nodule that is most likely benign. In this case, it's different. We are seeing a solid nodule too, but the borders are have like spikes, and those are the spiculated margins. So this nodule is most likely malignant. And in this case, we are seeing a nodule that is not regular, and it has some lobules. So this nodule is an ovulated nodule. Also, it's important to note that when measuring an spiculated nodule, it's important to not include the spiculations. Because if you include the speculation, then the size could be overestimated. So the recommendation the guide provides is that just measure the solid core and not the speculate. Another radiographic feature is an air bronchogram sign. So the nodule can have lucencies within it, and also air bronchograms. And those features should not mislead you to think that it's probably an infection. So in the left image, we are seeing a solid nodule that is heterogeneous. It has lucencies within it and air bronchograms. And in the right, we are seeing a solid nodule that is most likely lobulated and have some speculations also. Both nodules are suspicious for malignancy, but the air bronchogram sign provides a higher suspicion of malignancy. So the one in the left is more likely malignant than the right. And this feature is also described. I really don't know if it is used in the clinical practice, but it's described. And a contrast chest CT with contrast can be used for solid nodules that are spherical, homogeneous, without fat, disease, or calcification, and more than 5 millimeters, to rule out that the nodule is benign. So a first image is obtained before contrast, then one is obtained at 1 minute, then another one at 2 and 3 and 4 minutes. Then you look for the highest density obtained within the study, and you rest that with the pre-contrast density. So if the difference is less than 15 Hounsfield units, then it's most likely benign, and if it is more than 20, it's most likely malignant. This is the article, and here are the sensitivity and specificity. Okay, so with all that information, we can use some calculators that provide a specific probability of cancer. So in this case, this is a low-risk patient, a male patient, a young patient, no family history, no comorbidities like emphysema, solid, no prolonged location, no speculation, and a small size. So all that provides a cancer probability of 0.48%. This is an intermediate risk patient. So it's a female, it's older. It has a she has a ground glass nodule, no speculation, no prolonged, and the size is bigger. It gives a probability of 10%. Intermediate is between 5 and 65%. And this is a high-risk patient, female, older, partial solid, upper lung involvement, speculation, and a big size. So this provides a probability of 65%. So there are different scenarios. A scenario that clearly depicts a benign etiology is if the nodule meets criteria for stability on CT, or if the nodule have fat or benign calcification on CT, as I already discussed. In those cases, further workup is unnecessary and is considered benign. The other scenario is that the nodule is likely malignant. And if the nodule meets criteria for growth, then it should be biopsy or resected. And the intermediate scenarios are the ones in which the Fleischner guidelines are more focused on, and the management depend on different characteristics. So I will discuss them now. So if you have a solid nodule, an incidental solid pulmonary nodule, the first thing to do is to obtain a chest CT with thin section if it was detected on another modality. Then look for benign features. And now you have benign calcifications or fat. If the nodule has that, then it's considered benign, and a further follow-up is indicated. If the nodule doesn't have those benign features, then check change for at least 2 years. That is the threshold for solid nodules. Then is considered a stable, and further for no more than 2 millimeters, then is considered likely malignant, and biopsy or resection should be pursued. And if the nodule is unknown, then the next step is to evaluate the size. So if the size is less than 6 millimeters, so it's small, is considered benign, and for follow-up indicated. If it is 6 to 8 millimeters, a chest CT at 6 to 12 months since the nodule was detected is indicated. If the nodule resolves in this time, well, it's benign. If the nodule grows, it's most likely malignant, and biopsy resection should be indicated. If the nodule is unchanged, then it's important to evaluate the malignancy risk. If the risk is low, then it's benign. If the risk is high or intermediate, then another chest CT at 18 to 24 months. If the nodule is unchanged, it's considered benign. If it is unchanged after 2 years, and if the nodule grows, then it's considered malignant. If the nodule is more than 8 millimeters, then it's important to evaluate the risk. If the risk is high, then biopsy is indicated or resection is indicated. If the risk is intermediate, also biopsy or resection is indicated, but an alternative is PET-CT. This is specifically if patients they don't want a surgery or if the surgery risk is high. If the risk is low, then a chest CT at 3 months is indicated. If the nodule grows, is considered malignant. If the nodule, if the nodule is resolved, then it's considered benign. If the nodule is unchanged, then another chest CT at 9 months is indicated, and it follows the same pattern. If it grows, biopsy resection. If it resolves, not for a follow-up. If it is unchanged after 9 months, then another chest CT at 24 months, the same principle. And if after 2 years, the nodule is unchanged, then it's considered benign and a further follow-up is indicated. In this image, we can see a solid nodule. It has some lobulated contours, and we can see that the nodule increased in size over time. So this is considered with growth and most likely malignant. And the subsolid workup, if we identify a subsolid pulmonary nodule, it follows the same principle. Obtain a chest CT with dissection if it was detected on another modality, and check for prior CT images. For subsolid nodule, the threshold is 5 years. If the nodule is unchanged for 5 years, then it's considered stable and a further follow-up is indicated. If the nodule meets criteria for growth, the growth in subsolid nodules is different than solid nodules. So if the nodule meets criteria for these components that are in this black box, then it's considered malignant and biopsy or resection is indicated. Sorry. Okay. And if the nodule, if stability or growth is unknown, then it's important to evaluate the size and attenuation. If the nodule is partial solid and is small, it's considered benign. If the nodule is 6 or more millimeters, it's important to perform a chest CT at 3 to 6 months. If it resolves, it's considered benign. If it grows, it's considered malignant. If it is unchanged, then it's important to evaluate the solid portion. If the solid portion is more than 8 millimeters, then it's considered malignant. And biopsy resection is indicated, and an alternative is PET-CT. If the solid portion is less than 8 millimeters, then an annual chest CT is indicated. And if it is unchanged or resolved after 5 years, it's considered benign. If it grows, it's considered malignant. And if the nodule is a ground glass and is small, it's the same principle. It is 6 or more millimeters, then a chest CT at 12 months, and every 2 years for up to 5 years. And after 5 years, the nodule is unchanged or resolves within this time, it's considered benign, and if it grows, it's considered malignant. So this is an example of nodule growth. In the first image, we are seeing a ground glass nodule. In the second image, we are seeing that there is increase in density. This is also a feature of nodule growth in subsolid nodules. And in the third image, we are seeing that the nodule shifted from a ground glass nodule to a partial solid nodule. So this nodule is likely malignant. And in this case, this is the growth of a ground glass nodule. It was just increase in size, not increase in density, not development of solid component or another feature, just size. And it began at 13 millimeters and end at 18 millimeters in April 2016. So this is most likely malignant. So thank you very much for your time. And that's